We'll try and start on time and respect your time because it's Saturday afternoon, and we really appreciate you coming to this shift. It's a fascinating topic, I believe, we put together. So I'm going to just very briefly introduce myself and the program, and then we'll get on to the real exciting stuff. So my name is Alan Irvine. I'm the president of the IEC currently, and it's a real pleasure to introduce you to those of you who don't know much about the IEC. I'm going to tell you very briefly about it, then introduce our speakers and introduce our program. So this session is recorded. It'll be on the IEC website and on our YouTube channel, which we do within a few weeks. It usually get pretty high quality recordings, and they're there in perpetuity. So I encourage you, if you find it useful, to distribute it to your co-workers, team members, colleagues, anyone who's interested. Promote it on your social media channels if you find it of value. If you have any questions about the IEC, if you think you might want to join the IEC or make a contribution, contact Alan Stas or contact myself. Alan's email are there. Briefly, the IEC exists to improve the lives of patients with atopic dermatitis, to advance the field of research in atopic dermatitis, and we're celebrating our 10th anniversary today, continuing to grow. I'm pleased to say there's 34 countries now that we have, 174 counsellors and associates, and we're ambitious to grow that into more countries. We have some more countries coming on board before the end of the year. So if you know people from countries that are under or not represented, or if you're interested yourself, please do reach out and we'll discuss how we could have a contribution from you. We'd really welcome that. We've truly global reach. There's some Africa, Middle East and South America we'd like to grow our reach. Europe, North America, Asia Pacific, we're doing fairly well. We have counsellors and associates. Associates are early career physicians. Everybody has to prove demonstrable commitment to and achievement in atopic dermatitis. When you come, you have your unique perspectives, and we want to hear from you. There's a couple of things that are happening. The eligibility expanded this year. Well, last year we expanded to include allergists, so outstanding allergists have joined. I'm pleased to say many high-profile allergists active in the space of atopic derm are in the IEC now. This year, beginning January, we started to onboard PhDs who were active in dermatology research, specifically in atopic dermatitis research, and they're helping drive and broaden our offerings and our understandings. Our mission to improve patient care by research education and best practices for people with atopic dermatitis worldwide. Our vision is to transform the lives of people with atopic dermatitis. Our anthem, we're a global community, which we try to show, but we want to grow even more, of leaders in atopic dermatitis research, treatment, and prevention. And our values, patient-centered, innovative, evidence-based, globally inclusive, collaborative, and forward-looking. And hopefully this session will demonstrate that curiosity, that commitment to improve lives, to bring evidence-based knowledge to care. We really rely a lot on corporate support, and we're hugely grateful to our corporate support that supports our mission. It's all arm's length funding. We have produced a lot of educational impact. That's not including today's session. We've produced 47 symposia. The great majority of these, not all, but nearly all, are on the YouTube channel and easily accessed. We've had more than 150 individual expert speakers, and we've 26 countries represented by speakers, and we want to move these metrics up and be as inclusive as we possibly can. And these are the videos. We have over 100 hours of videos, and tens of thousands of people view them. This is what we're doing this year. We've this meeting, which obviously you're all at and know about, and then we have the Inflammatory Skin Disease Summit, which happens every 2 years, alternates between Vienna and New York. Patrick Brunner, who's with me, is key organizer of that. That's going to be discussing alopecia areata and atopic dermatitis, the challenges and opportunities around clinical trial design and recruitment and shared learnings. And then we have a number of meetings planned for 2026, starting in the EAD in Denver, the SID in Chicago, RADLA, which Valeria Aoki will take a lead on. We do every second year on the ESDR. That should come around next year. And finally, we'll be back in Vienna with all of you, hopefully, and the date, I think, is the end of September. We didn't have it, I think it's the 30th. So we're active on social media, whichever your preferred platform. We're probably most active on LinkedIn and YouTube. We find those channels that kind of match our offerings best, but we also have all of the standard social media platforms, X, Instagram, and Facebook. You can watch the videos, which I've mentioned, including today's in a few weeks' time. Any questions? Alan is the go-to, but you're welcome to contact me too. This is our program guide, which you can scan and download, and we're going to take you through the program now. First of all, I want to introduce the chairs of the program. I want to introduce Yale and Patrick. These are two leaders in atopic dermatitis research and treatment, people who've really made a massive contribution, and personally, for me, they make a massive contribution to how the IEC produces content. Yale's heavily involved in the educational committee, Patrick heavily involved in the research committee, and I'm hugely grateful to the contributions they make. Yale, I'm sure most of you know Yale Yashin, but she's a dermatologist and clinician scientist in the Atopic Dermatitis Clinic in Rabin Medical Center and has a professorial appointment at Tel Aviv University in Tel Aviv, obviously. And she's made a great contribution publication-wise and treatment-wise over the years. Patrick Brunner, formerly of Austria, now of the ICTHAN Medical School in New York at Sinai. Patrick has had a long-standing interest in the translational aspects of inflammatory skin disease, spanning a range of skin disease, including atopic dermatitis, and more recently has become an expert in translational sorting and sectoring of cutaneous T-cell lymphoma. So these are really appropriate experts to lead us through this session. So I'm not going to take any more of your time. Do scan, do follow us, link in and get engaged with the work we do, suggest, contribute what we could do better. And without further ado, I'm going to introduce Yale first. Thank you very much, Yale.
Thanks, Alan. So thank you, everybody, for coming today. We have a really, really exciting session. Looking forward to hearing all the talks. And you might ask yourself why we're discussing that differential between eczema and cutaneous T-cell lymphoma, because that complex differential is nothing new, really. We've been talking about it for a long time. But we think this session is really timely in this era of advanced therapeutics for atopic dermatitis, which are starting to raise a lot of questions regarding that association with cutaneous T-cell lymphoma. So looking forward to a very productive session. Patrick, do you want to go over the program? We have that?
Yes, thank you so much. Thanks so much for you all coming here at this late hour. And we're very excited to present you this program where we want to dive into the sort of relation of atopic dermatitis and CTCL, both on a diagnostic as well as on a therapeutic level, particularly given the new treatments that have come out. And there's a lot of controversy around these topics, and I hope we're going to have lively discussions and that we can sort of see what is the current state of the art.
Okay, so without further ado, it's my great pleasure to introduce our first speaker, Dr. Pietro Quaglino. Dr. Quaglino is the chair of the Dermatologic Clinic and professor of dermatology at the University of Turin in Turin, Italy. He's a very, very prolific researcher, and he has a lot of interest in dermato-oncology, specifically in cutaneous T-cell lymphoma. He was on the board of directors of the International Society for Cutaneous Lymphoma and on the Cutaneous Lymphoma Task Force of the EORTC. But he also has a research interest in immune-mediated skin diseases, so I think he's perfect to provide us this first talk.
So, good afternoon, everybody. Thanks for this nice presentation, and thanks for the involvement in this challenging session about CTCL and atopic dermatitis. It's for me an honor to be part of this session and discussion. I'm looking forward for sharing evidences and discussion with all of you. I will try also to convince you that the problem of association between atopic dermatitis and CTCL, both mycosis fungoides and Sézary syndrome, is not only a problem of differential diagnosis, but could be, and we have to work about that, could be also a potential of association. And this will be discussed both for diagnosis and for lesions arising during treatment. And I will focus my presentation particularly on from the diagnostic point of view at the beginning, and also problems related to diagnosis during treatment. But let's start from the beginning. These are two well-known cutaneous diseases. For sure, atopic dermatitis is less common than mycosis fungoides. And at first glance, these two diseases are characterized by completely different clinical features. And you see age of onset, predominantly childhood versus adults in mycosis fungoides. Itching, very common in atopic eczema, variable in mycosis fungoides, very common in Sézary syndrome, which is the erythrodermic and leukemic variant in the spectrum of CTCL, but characterizing only 2% of all cutaneous lymphoma patients, so very, very rare. Type of lesion, erythema and vesicles for atopic eczema, and as I will show you, progression of different lesions in mycosis fungoides, rapid versus slow progression. Also, topography is completely different. All of you are familiar with the involvement of the flexural areas and periorificial in child and the adult atopic dermatitis is different in newborn and completely different in mycosis fungoides involving the sun-protected area of the swimming suit areas of buttocks and thighs and abdomen. And histology also is in the well-developed cases different, spongiosis and eosinophils versus atypical lymphoid cells. But I'm going to show you that in some cases it can be difficult to differentiate the two aspects. And here you see some examples, the common eczematous vesicular lesions on the flexural areas had involvement. And the other hand, the progression of mycosis fungoides, the most common CTCL subtypes, male prevalence and age of onset around 50, 60 age, so in adulthood, not in children like atopic dermatitis, and characterized by this clinical progression from patches to plaques, tumors, and eventually erythroderma, with the possibility in advanced stages to develop extracutaneous involvement with blood, nodal, or visceral lesions, and particularly blood involvement associated with erythroderma, characterize the so-called Sézary syndrome. And we are here in Paris, so we have to remember that Sézary was a French dermatologist who in 1939 described for the first time this entity. What about diagnosis of mycosis fungoides? Diagnosis cannot be made only on clinical features, but relies in the associated evaluation of clinical as well as histological, molecular, and immunopathological features according to the ISCL algorithm published 20 years ago. And in particular, a clinical point of view for early lesion, patches and plaques in non-sun exposed location with slow, very slow progression. However, particularly in the early phases of mycosis fungoides, diagnosis is not easy because early clinical signs and symptoms can be mistaken for other inflammatory skin dermatosis, more and more common. And therefore, mycosis fungoides has been characterized as a mimicker of other conditions, erythematous lesions, scaling lesions, and also eczematous lesions. So we go into the focus of the differential diagnosis, which in early phases of mycosis fungoides cannot be so easy. So the important message since the beginning is try always to perform a biopsy and review with your pathologist to make clinical pathological correlation and to establish the correct diagnosis. And to witness the complexity of this topic, I'm going also to show you this very nice table taken by a paper published by my friend and next speaker of the session, Amy Odak, which, as you see, present a variety of different variants and subtypes of mycosis fungoides, apart from the classical one that I showed you. And indeed, you can also see between all these variant, the vesicle bullous variant of mycosis fungoides. So different, but so there can be problems in differential diagnosis. And what about pathogenesis? Are there any shared mechanisms between the two entities? I'm going to say yes, even if these two diseases are completely different overall. One is inflammatory, one is neoplastic. But focusing on the pathogenesis of mycosis fungoides, even if it's not completely understood anyway, we know that there is a chronic antigenic exposure, some antigens, viral, that stimulate a polyclonal proliferation of lymphoid cells that, after several mutations, can become monoclonal, therefore neoplastic. And the phenotype of these lymphoid cells, these are T helper, and there is a switch, and you see in this beautiful cartoon taken from a paper by Professor Emanuela Genova, another speaker of the session. There is a switch from a predominant T helper 1 phenotype in mycosis fungoides early stage towards the T helper 2 phenotype. So similar to that of atopic eczema, and moreover, bacterial agents have been suggested to play a potential role in the pathogenesis of mycosis fungoides, Staphylococcus and Streptococcus, through different mechanisms. As you see here, suppression of anti-tumor responses, induction of pro-inflammatory cytokines, leading to selective expansion of these malignant clones. Therefore, as you see, comparing these pathogenetic features of mycosis fungoides with the well-known pathogenesis, not well-known, but again, as you can see here, what we know about pathogenesis of atopic dermatitis, you can easily see that there are these features that are common pathways of both diseases. So chronic stimulations, relevance of bacterial superantigens, and T helper 2 responses. And indeed focusing also on the antigens that represent the targets of biological treatments, so the IL-4, IL-13 pathway. This pathway plays a major role also in the growth, proliferation, and expansion of mycosis fungoides cells, as lymphoid cells in mycosis fungoides clearly express surface receptors related to T helper 2 inflammatory pathways. So I'm going to show you that we have a problem of differential diagnosis and consider always biopsy and clinical pathology correlation, as if one biopsy is not sufficient, take another one. For mycosis fungoides, we don't have problem of acute development. In the majority of cases, is low progression. So it's better to wait and to perform another biopsy before making the final diagnosis. But the second point that we're going to share with you is there a possible association between the two diseases or evolution from atopic dermatitis to mycosis fungoides? And indeed, coming back to the literature, there are several studies that suggested and showed that patients with atopic eczema, so focusing on starting atopic eczema patient, can have a slightly increased risk of developing CTCL/mycosis fungoides or Sézary syndrome. And you see here some population-based study, a Danish cohort study, particularly increased risk in patients diagnosed as eczema with chronic and unresponsive disease outcome to standard treatments. Therefore, keep in mind that risk is low and some part of this association may reflect initial misdiagnosis or delayed diagnosis. This paper analyzed a very large cohort, around 1 million patients, both pediatric and adults, with atopic eczema, trying to identify the risk of developing malignancies, solid and hematologic. This is the pediatric cohort. Emi Odak will focus on this talk. We can just say that at the last part of the slide, you see there is a slightly increase, but not statistically significant, in pediatric patients with AD to develop CTCL. On the other hand, in the adult cohort, the risk at the bottom seems to be higher. You see overall, AD patients don't seem to have a specifically increased risk of malignancies, but for CTCL, yes. And you see here that this is true for mild, moderate, and particularly severe. I think that this reflects again the potential of wrong or delayed diagnosis in these cases. But I think that the increased risk, and you can focus on this 3.9 overall, 1.6 in mild, 5 in moderate, 21-fold increased risk in severe cases, perhaps suggests the potential of some treatment-related effect in this percentage, okay? Keep in mind that, and we will come back to that. On the other side, it's interesting to see the opposite evaluation. Therefore, in patients with mycosis fungoides Sézary syndrome, which is the percentage of atopic eczema or atopy, so the opposite evaluation. And we have two studies, not so recent, but published by leading groups in CTCL, that clearly show that the percentage of patients with mycosis fungoides showing atopy or the atopic dermatitis is low and same than in patients without the general population. And this was true in this UK study, and the same in this study from the US. We showed also the potential increase of IgE and the eosinophils, particularly in advanced stages, is common for the Th2 pattern. Therefore, we have different story from these papers. So from one side, studies in AD showed potentially increased risk of CTCL. Studies in mycosis fungoides Sézary syndrome failed to demonstrate a significant percentage of AD. Meaning, in my mind, that an important point to that is that there can be a bias, an issue related to the wrong, delayed diagnosis. But perhaps it's not only this problem, because remembering the higher percentage in severe cases, this opened the field for considering a progression from AD to mycosis fungoides associated with the common shared pathogenesis, and perhaps worsened, exacerbated by the drugs. And as you know, starting from cyclosporine immune suppressive drugs, then we have IL-4, IL-13 blockers, and JAK inhibitors. So both biological and JAK inhibitors will be the topic of next talk, so I don't want to go into details, but just focusing on the promise of diagnosis. As you know, there are a lot of reports, and these are only the most recent ones, showing evidence of mycosis fungoides in patients treated with dupilumab, tralokinumab, or other IL-4, IL-13 blockers for atopic dermatitis. And I wanted to show you a couple of cases from our clinical daily life. This is a 63-year-old male, AD since childhood, treated during years with several treatments. He was started with dupilumab in another center in 2023, with good response. And you see here in the back when we saw the patient complete healing of lesion with some residual hyperpigmented lesions, but complete clearance. But during the treatment, these men developed, increased the thickness of some small lesions on the head and scalp. And here you see some example, some clinical pictures and details of the lesion when we saw the patient, and indeed it was slightly infiltrated. We performed a biopsy, and in this lesion there was evidence of folliculotropic mycosis fungoides. So the question, and what does this clinical case teach us, especially at the long history of AD? So there was a pre-existing AD, and then what happened? There's simply an association of mycosis fungoides after, or progression induced by the drugs. So AD and CTCL coexisting in the same patient, AD evolution to CTCL, wrong AD diagnosis, we don't know, but this patient, 63-year-old, had history of AD since the childhood, so it seems difficult that this patient had mycosis fungoides since the beginning. And the second, even more impressive case, and I have to check the hour because time's running fast. This is a 45-year female patient with familiar history of atopic eczema, but not previous diagnosis of atopic eczema. And she developed, so pay attention in these cases, with adult onset AD without previous history of AD, developed these lesions less evident on the trunk with a specific head and face involvement, also with bacterial infection. Histology was performed, was superficial dermatosis with spongiosis, blood test normal. She started dupilumab in 2020 during COVID pandemic, so he received biological as first systemic treatment. And during the treatment of dupilumab, some more lesion appeared on the back, and particularly there was a dramatic worsening of the face, perhaps also with herpes simplex infection. And 6 months after the beginning of dupilumab, another biopsy demonstrated Sézary syndrome with a really important blood involvement. We are sure that at the beginning this was not present. So definitely we don't know what happened. And again, it's important to consider that Sézary syndrome erythroderma, but erythroderma is not in all the cases the first presentation. In our experience published some time ago, 27% of patients with Sézary syndrome had first lesion as eczematous lesion, and in this important paper published in 2017 from different centers, you see also other friends participating to the author list. Again, the first cutaneous signs of Sézary syndrome was non-specific dermatitis and atopic dermatitis like eruption. Perhaps the patient that I showed you could belong to this group. So overall, which are the data reviewed and present in the literature? This is a meta-analysis showing that the characteristic of mycosis fungoides and Sézary diagnosis in AD patient treated with dupilumab is more consistent with in patients that developed AD in adulthood. In the majority of cases, had non-typical lesion of AD. And in this review, it appeared that only a few cases had demonstrated long-standing AD, perhaps then developing mycosis fungoides Sézary syndrome or unmasked after the treatment. In the other part, it was unclear whether this patient had truly AD since the beginning. And other paper confirmed and reported this data. There are also hypotheses suggesting the role of dupilumab in this unmasking mycosis fungoides Sézary syndrome. And one of the hypotheses is that the blockade of IL-4, IL-13 receptor can induce increase of free IL-13 that can bind to a less known IL-3A2 receptor, which have a role in promoting tumorigenic pathway, as well as other hypotheses, disequilibrium in cytokines reflected in this paper. Just coming back to diagnosis, and again, to highlight the complexity of these cases, it has been reported that dupilumab can induce the so-called cutaneous lymphoid reactions. So during the course of dupilumab, patient can develop these lesions, which are macular, papular, coalescent, sometimes also vesicular, that biopsied present the aspect of superficial perivascular infiltrate CD4 positive. And in this case, we have to be very careful. The indications are to suspend treatment, and the majority of these cases are gonna clear. But in this patient, sometimes a review, as reported here in this paper, highlight the potential of mycosis fungoides before, in other not. Again, we have to follow this patient to see what happened. So in this case of cutaneous lymphoid reaction, dupilumab associated, from a clinical point of view, what is important is to closely monitor this patient, repeat skin biopsy, and discontinue treatment and following the disease. Another well-known drug used in atopic dermatitis, JAK inhibitors, just to focus on that because this is a group of drugs that have shown important role in atopic dermatitis because they go to interact with immune mechanisms related to inflammation. But we know also that this regulation of the JAK-STAT pathway can be one of the leading mechanisms of CTCL. And indeed, some cases treated with JAK inhibitors with mycosis fungoides or atopic dermatitis and then unmasked mycosis fungoides. In this case, mycosis fungoides was a positive response. So we have to know better into details in this group. And for all of you who are interested, perhaps Amy Oda will give more information about that. There is an ongoing EORTC study collecting cases with mycosis fungoides treated with JAK inhibitors. Just to conclude, a short cases, again, to witness the complexity of this association. I presented this case also in Singapore. So a male, 67 years old, onset of pruritic dermatitis with exudation in the last 4 months, localized, as you see, on the left part on the face and the neck. We performed mycological test negative. I think that all of you, based on this clinical picture, could hypothesize some kind of eczema with these vesicles and crust and erosions. However, this was not the only lesions, but other lesions were more evident. And you see some of these, like this on the hands, were more eczema-like, other on the trunk. Or you see these very large patches, even if some erosions here are more suggestive also of mycosis fungoides. Indeed, I have to say that if a patient has a genetic background of atopy, probably he will develop mycosis fungoides with some features related to his genetic background. The first cutaneous biopsy, as you see, mild infiltrate, superficial, perivascular, CD3, very sparse cells. Therefore, the diagnosis was spongotic dermatitis. You see in the epidermis, the classical lesion, and was treated with systemic antibiotics and steroids. However, the lesions did not have a good disease outcome. Indeed, there was a rapid worsening of the lesions, as you see here, with development of these more infiltrated lesions and also involvement of the part of the scalp. And the second biopsy was taken some months after, and the histological picture was completely different with a diffuse lymphoid infiltrate with epidermotropism, small to medium, but also some large cells, CD3 with folliculotropism, as you see in the picture, with involvement of the scalp. And therefore, the final diagnosis was mycosis fungoides plaque stage with vesicular and folliculotropic features. And unfortunately, the patient, in spite of repeated treatments, died to sepsis September 2022. So focusing on this vesicular mycosis fungoides, which is a variant, very rare, of mycosis fungoides, there are some clinical cases reported. We don't know if this is an eczematiform reaction triggered by mycosis fungoides or mycosis fungoides in a patient with a pre-existing atopic background. But what is shared by all these cases is a generally aggressive disease course, probably related to Th2 pattern also associated with atopic dermatitis, or in some cases due to delayed diagnosis. So this is the last slide of my talk. Just the clinical message for me and for all of you, if you agree that it's a very complex topic and we are accumulating more and more evidence, but it was important to consider that the biopsy and clinical pathologic diagnosis is essential at first to try to distinguish the two entities, and during treatment and follow-up to see, first of all, if our first diagnosis was correct, and to see if there is a potential of association of development due to cytokine mechanism in our patient. So thanks so much, and waiting for your question.
Thank you so much, Dr. Coglino, for this comprehensive overview. We will do a Q&A session at the end of the third talk. Okay, so we'll do a Q&A at the end. It's my great pleasure to invite Dr. Amy Chodak. Dr. Chodak is a professor of dermatology and the director of the Cutaneous Lymphoma Service at the Davidov Cancer Center, Tel Aviv University in Tel Aviv, Israel. She's the immediate past president of the International Society for Cutaneous Lymphoma and a board member of the EORTC Cutaneous Lymphoma Tumor Group. On a personal note, Professor Chodak is an inspiration and a teacher for many, many dermatologists, myself included. It's always a privilege to hear her. The floor is yours, Amy.
Okay, good afternoon. Thank you so much, Dr. Leshem, for your nice introduction, and for you and to Dr. Brunner for inviting me to share my 25-year experience with pediatric MF, with special focus of atopic dermatitis like mycosis fungoides. And what's on the menu? I will start with short introduction, and thereafter I will share with you clinical cases that mimic atopic dermatitis and what were the clues for the correct diagnosis. And the prevailing notion of all of you probably that atopic dermatitis is a disease of childhood, adolescence, and mycosis fungoides of adults. Well, truly, mycosis fungoides typically affect adults, but MF can also affect children and adolescents, and the mean age of diagnosis is 12 years. However, there is a wide range in the reported worldwide incident rates, and as you can see in this map, it can be as low as up till 3% in North America and Europe, but it can as high as 1/4 of newly diagnosed mycosis fungoides patients in Southeast and in the Middle East. So these regional differences may reflect a true epidemiologic variation, but may also be explained by a variable index of suspicion. So this was one of the youngest patient that was diagnosed with mycosis fungoides in our department. You can see here well-defined patches in sun-protected areas, some of them with fine scales. So, could it be mycosis fungoides? Yes, this was mycosis fungoides. How does pediatric mycosis fungoides differ from its adult counterpart? So you all know that in adults, the majority of cases are the classic patch plaque type of Eliber-Bazin, MF. In sun-protected areas, well-demarcated patches and plaques with fine scales. However, in children, this phenotype is found in the minority of cases. But the majority of pediatric patients present with unusual variants, which often mimic benign dermatoses that are common in this age group, especially atopic dermatitis, and especially its associated eruptions. And as you can see here, white patches mimic pityriasis alba AD. This is hypopigmented MF. And on the other hand, you can see widespread keratosis pilaris-like lesions that actually is a manifestation of folliculotropic MF. So MF is underdiagnosed in the pediatric age group not only because of this unusual presentation of MF, but also we all have low index of suspicion, and also there is a reluctance to perform biopsies in children. Therefore, the mean time to diagnosis is 3 years. So I just want to show you two series. One of them, table 1, 71 patients from our center, in which you can see that almost 30% of the patients were initially diagnosed with non-specific dermatitis or atopic dermatitis. And here you can see a smaller series in which almost all of them were diagnosed initially as eczema, pityriasis alba. And what is unique here is that almost all of them had early stage disease. And this phenomenon is not unique to these two series, but in fact, almost all patients are diagnosed at an early stage of disease, manifested by patches, papules, and plaques. And the course is strikingly indolent, and progression to advanced stages is extremely rare. So now I would like to share with you some examples from our daily clinic of early-stage pediatric MF misdiagnosed as atopic dermatitis and its related features. And the first one was an adolescent that presented to us with these plaques that looks unequivocally as atopic dermatitis. Yes, even in the wrist joint, you can see here very nice lichenified plaque. However, upon anamnesis, there was no pruritus. So this was the red flag in this case. And in fact, pruritus is uncommon in early-stage pediatric MF, and less than 10% of them complain of itch, and the itch is not prominent as in atopic dermatitis. So what is the conclusion from this first case? Lack of pruritus or mild pruritus, even in the presence of otherwise conventional AD, please think about AD like MF. The second case I would like to share with you was a 10-year-old girl. There was no personal or family history of atopy. And the patient was referred to us because of an asymptomatic eruption of 3 years duration with periods of regression and aggravation. She was diagnosed as having widespread pityriasis alba atopic dermatitis and was treated with topical corticosteroids with only partial response. And I would like to show you some of her features. You see on the cheek wide, large, hypopigmented patch. You can see on her outer aspect of her upper limb, you can see confluent patches and plaques. Some of them are well demarcated, and all of them are hypopigmented. And upon further physical examination, you can appreciate that the lesion extends to the shoulders, to the back, with some bizarre shaped lesions and fine scales. and even extension to the lower limbs. So is it atopic dermatitis as she was initially diagnosed? Well, although there are pityriasis alba-like lesions which are part of the associated features of AD, but main essential features of atopic dermatitis were absent except for chronic or relapsing course. So it wasn't atopic dermatitis, actually. So was it pityriasis alba as a standalone entity? Well, the location was unusual, involvement of areas not typical to PA, and widespread distribution, and the morphology was also very unusual. Well-demarcated macules, large macules more than 2 centimeters in diameter, variation in size and shape. So it's not really a pityriasis alba. So there is a large DD in this case, but I will skip because we will focus on atopic dermatitis NMF, and the last possibility was it a hypopigmented MF? And yes, we obtained biopsy from different types of lesions, and in all we saw unequivocal changes of mycosis fungoides, but with some unusual finding. As you see here, the CD3 nicely highlights the intraepidermal lymphocytes as well as the intradermal lymphocytes. However, when we stained for CD4, the intraepidermal lymphocytes were negative, as opposed to CD8, which nicely stained the intraepidermal lymphocyte. So this was a case of hypopigmented MF, CD8 immunophenotype. So just a little bit to remind you about this entity, is the most common type of MF in pediatric population, up to 90% in some series, affects all skin types, but especially in darkened skin types. Unlike classic distribution of MF, the outer aspect of the upper limbs are involved as opposed to the inner aspect of the upper limb in classical MF. Many cases exhibit a CD8 positive immunophenotype and can be the sole manifestation of MF or in conjunction with other types of lesion, classical, but specifically folliculotropic MF. And just to show you another boy misdiagnosis with AD pityriasis alba, what were the clues here that led us to obtain biopsy? No pruritus, confluent of lesions, and alopecia. Please look here, the hairs, and here all of the sudden, no hairs. And we obtained biopsy, and we show nicely the perifollicular and the intrafollicular lymphocyte infiltration that's sparing the overlying epidermis, which this is a case of hypopigmented and folliculotropic MF. And another similar case, but here, in addition to no pruritus and alopecia, please note the follicular accentuation in the pityriasis alba-like lesion. And we obtained biopsy, and again, we saw that the action is around and within the follicle with many atypical lymphocytes, and the diagnosis was hypopigmented and folliculotropic MF, mimicking pityriasis alba. So what are the insights of all these cases? Pityriasis alba lesions with unusual features, including unusual distribution, confluence of lesions, variation in sizes, shape, follicular accentuation, localized alopecia. Please think about pityriasis alba, atopic dermatitis like MF, hypopigmented variant with or without folliculotropic MF. And just to those of you who are not really familiar with folliculotropic MF, is the second most common type of MF after hypopigmented variant, wide range of manifestation, erythematous, hypopigmented scaly patches and or thick plaques with follicular accentuations, and or keratosis pilaris-like lesions, and or acneiform lesions, with or without localized alopecia within the lesions in hair-bearing site. And they are located mainly on the trunk and limbs, and can be the sole manifestation of the disease, but more often presents in combination with hypopigmented variant and less often with classic MF. and can easily be overlooked due to subtlety of the findings, especially in very young children with very fine vellus hair. You can't really appreciate the alopecia, and sometimes it's very difficult to appreciate the follicular accentuation. So just to show you, keratosis pilaris like atopic dermatitis like MF, this was a 4-year-old girl that presented to us with widespread. It's very difficult to see. I hope you can appreciate that all her trunk is studded by fine follicular lesions, and here on the limb you can see cluster of keratosis pilaris-like lesions, and it was really unusual distribution to keratosis pilaris. So what was the pro for thinking about atopic dermatitis, keratosis pilaris? The sister had similar eruption, and we know the keratosis pilaris is associated with atopic dermatitis in up to 40%. However, not in such a distribution. There was no pruritus. There were a cluster of keratosis pilaris and no typical lesion of AD. And we obtained biopsy, and again, this is an unequivocal case of KP-like folliculotropic MF. So the insight of these cases are keratosis pilaris-like lesions with unusual features, including involvement of atypical locations, cluster of lesions, sometimes on well-demarcated patches, and or localized alopecia, absence of features of AD. Think about KP like MF. And the last case in this series of early stage pediatric MF mimicking AD or its associated features in the following case. He was a 40-year-old boy, family history unremarkable. He was referred to us because of an eruption associated with mild pruritus of 2 years duration. The initial diagnosis was atopic dermatitis, and he was treated with topical steroids with only partial response. And we first examined him. We thought, well, it's unequivocal typical eczematous plaques of atopic dermatitis. However, upon further examination, we noticed that on his knees, there are hypopigmented patches and flat plaques with prominent follicular papules and localized hair loss and even some folliculitis. And on his shins, we noticed patches devoid of hairs with very nice keratosis pilaris-like lesions. So the question in this case, is it a coexistence of atopic dermatitis and folliculotropic MF? Can be, or everything is mycosis fungoides. So in this case, we obtained biopsy from different types of lesions, including the AD. And everything came up, mycosis fungoides, in fact, folliculotropic mycosis fungoides. So the take-home message from this case is that although AD may coexist with MF as presented by my friend Pietro, biopsy should be obtained also from lesion typical for AD to rule out diagnosis that everything is AD like MF. So and now I will conclude my talk with the only case that in my career I encounter with advanced stage pediatric MF misdiagnosed as atopic dermatitis, because advanced stage in pediatric population is extremely rare. So this was a 15-year-old boy. At the age of 4, he underwent renal transplantation. He was put on immunosuppressive medications, as you can see here. 2 years later, he developed cirrhosis associated with severe pruritus. And 1 year later, he was diagnosed as atopic dermatitis due to the presence of eczematous plaques over the antecubital fossa, lichenification, and severe pruritus. When he presented to us, he was totally erythematous, actually erythroderma, and he had numerous keratosis pilaris-like lesions on his body. And here you could see on the thigh, here you can see remnants of hairs, but actually he was totally alopecic. And here in the, behind his knees, you could appreciate impetiginization and lichenification. So what were the red flags here? The red flags here were that he was a renal transplant patient and on immunosuppressive medications. And in fact, his atopic dermatitis developed on this unusual immunosuppressive scenario. So we decided, of course, to obtain biopsies. And as you can see, this is folliculotropic MF, and he was finally diagnosed as erythrodermic folliculotropic MF, stage 3. Just to let you know that post-solid organ transplant lymphoproliferative disorders is not uncommon, and actually most common malignancy in pediatric solid organ transplant recipients is these entities, occurrence up to 4%, and MF diagnosed in this population is usually diagnosed at an early stage with overrepresentation of folliculotropic MF and of children. So symptoms and signs typical to AD appearing after commencement of immunosuppressive treatment, especially in solid organ tumor recipients, please think about mycosis fungoides Sézary syndrome. And follicular lesions, especially in skin of color, are common in atopic dermatitis, but there are surprises. So, what is the take-home message of my short presentation? I hope I made it. First of all, you have to think about the unusual presentation of MF. You need to have high index of suspicion, even in children. And the clinical flags for pediatric MF in patient diagnosed with AD and related features are lack of personal or family history of atopy, unusual AD, and specifically lack of pruritus. This is one of the most important clues for not diagnosing AD. Unusual pityriasis alba, unusual keratosis pilaris, and if you want to know whether it's a dove or a hawk, please obtain biopsies from many, many lesions. And last but not least, collaboration with the Cutaneous Lymphoma Referral Center is valuable, especially when features remain ambiguous. And for those of you who are interested in the field of pediatric MF, I would like to invite you to read the 2 parts of our recently published ISCL, URTC, USCLC recommendation for the diagnosis, staging, and treatment of early-stage pediatric mycosis fungoides that published in the British Journal of Dermatology. And with that, I thank you for your attention. Thank you.
Thank you so much, Amy, for this excellent overview of pediatric MF. As I said, the Q&A will be after the next talk. So it's my great pleasure to invite my co-chair, Patrick Brunner, which has already been introduced. And Patrick apparently is going to give us the answer on how to tell atopic dermatitis apart from cutaneous T-cell lymphoma. The floor is yours, Patrick.
Thank you so much for a kind introduction. So my title is, unfortunately, a bit of an overpromise. So of course, it's still very difficult in certain instances to differentiate those two. But I want to show you some data on after seeing these excellent clinical talks, what we can do molecularly. Molecular investigations will not be the answer. You will still need a good clinician, a good histopathologist, but there are certain attempts to find biomarkers in order to help make this diagnosis. So these are my disclosures. So I'm particularly thrilled to give this talk here in Paris, where you have this long, long line of pivotal CTCL research and giants in cutaneous lymphoma research, starting with Aliver over Sézary and Brock, and Professor Bargot from St. Louis is here. So she's part of a long line of excellent researchers in CTCL that really made the difference. I'm from New York, so there was also there were also sort of back then, because I have an interest in the history of dermatology, certain researchers that would deal with cutaneous lymphomas. This is a famous atlas by Fox, Henry Fox, and he already wrote that the early stage of mycosis fungoides is often characterized by an eruption which looks very much like dry eczema. So that has been known for a very long time, and often it's really very, very difficult to make a difference or to diagnose CTCL versus atopic dermatitis or eczema on a clinical level. You can take a biopsy, of course, and if you have a propensity of CD4 versus CD8 and maybe loss of CD7, then you are quite confident that this might go into the direction of mycosis fungoides, but still differences can be subtle, and often you get biopsies back as spongiotic dermatitis or unspecific dermatitis, and you are stuck. So when we look at the molecular underpinnings of cutaneous lymphoma versus eczema, when we look at atopic dermatitis or eczema, there have been many studies have been being performed, molecular studies have been performed, characterizing the immune infiltrate in atopic dermatitis, and there are variations across populations depending on their background, adult versus childhood, Asian AD, African American AD, or also AD from European descents. There are various parts of the immune system that are being activated, but one uniform factor in atopic dermatitis is type 2 activation, Th2 activation, which is now, of course, blocked with Th2 blockers, and often the disease can be treated sufficiently. Th2 immune activation in CTCL is also found, but particularly later in the disease stage. So when you have early stage mycosis fungoides, you have more of a Th1 immune response that is thought to be more sort of tumor suppressive, but with ongoing disease, you have more and more of a type 2 Th2 activation. So later in the disease, you also have this kind of immune activation that you also find in atopic dermatitis, and it's not going to help you to differentiate those two conditions. Another challenge is that these kind of immune activations can fluctuate after treatment, of course. Emanuela Guenova has nicely shown that when you treat a Sézary patient, for example, the Th2 bias goes down and Th1 goes up again. And when you look at individual tumor clones, they can be very different in their cytokine expression profile depending on the body compartment. So there's a lot of fluctuation, a lot of plasticity in those malignant cells that makes it also so difficult to really pin down certain biomarkers that could be used as a uniform diagnostic marker to know whether it's eczema or AD. And also atopic dermatitis is a quite heterogeneous disease. So this was an attempt by the groups of Emanuela Guenova and Kilian Eyrich to develop a histology-based classifier. Many classifiers or many histopathological clues were used, and at the end of the day, what correlated best with a histology-based classifier to distinguish early mycosis fungoides from atopic dermatitis was really the atypical lymphocyte, both in the epidermal and the dermal compartment. And this is, I think, a good evidence to further look into the malignant clone themselves in CTCL, because they might give you the best source of potential biomarkers to differentiate those diseases. So in order to better understand whether a clone is present or a clone is absent, for many years, T-cell receptor rearrangement, a PCR-based assay has been used. Now we have a next-generation sequencing available in many centers that gives you a more nuanced and a more sensitive and specific look into cutaneous skin lesions, but also those tests are not 100% specific and sensitive, so they can help you make the diagnosis, but at the end of the day, by themselves, they will not be able to differentiate it. Because when you look at this review article, so that sensitivity for TCR next generation in the skin ranged between 70% and 100% compared to lower rates in PCR, where specificity was also in that range, but not necessarily 100% in all studies. So we are still a little bit better than PCR-based assays, but just testing it molecularly for a clone by itself most likely will not lead you to a diagnosis in difficult cases. One thing that is very interesting about next generation sequencing is that the amount of clone, if you find the clone, the amount of clone can give you an idea about the prognosis of the patient, because it's often not only difficult to diagnose cutaneous lymphomas, it's also very difficult or impossible to really predict whether the patient will be stable or whether the patient will progress. And this is, I think, a pivotal study that gives us a first idea about how one could develop biomarkers, or one biomarker that could give us an idea whether a patient will progress or not, because when your tumor clone frequency is higher, you have a higher risk of progression, but this is not yet a clinically, not yet a test that is clinically routinely available. I personally have a lot of interest in single-cell RNA sequencing. I'm not going to sell you single-cell RNA sequencing as a routine testing method to differentiate your patients, but I think it's now the best way to really understand what's going on in lymphomas and to quantify those cells. Single-cell RNA sequencing works a way that you take a biopsy, you generate a single-cell suspension, and then you encapsulate every cell, and you can get a transcriptome of every cell that you have. And here on the top left, you see, for example, a CD3, or you see a single-cell data set. Every dot represents one single cell, and some bioinformatics algorithms will group you those cells according to their expression profile. And then you can look which cell expresses which marker. So for example, here CD3D is of course a marker for T cells, and CD3 positive cells are marked in red here, and you can see that in this sample there are lots of T cells. The nice thing about single-cell RNA sequencing is that you can pair your data set with the T-cell receptor information, so you can look which of these cells express a T-cell receptor, and those ideally should be, of course, overlapping with the CD3 signal. So here you can see that the CD3 positive T cells in this plot or essentially all express a T-cell receptor. And then you can look at the individual T-cell receptor and see how the overall TCR repertoire looks like. And when you look at this sort of Gaussian distribution, this is a polyclonal TCR repertoire, and this, of course, is a monoclonal repertoire. And then you can map out your top expanded clone in your data set. And when you look at healthy skin, for example, so those are 4 samples. In light red, you see the polyclonal infiltrate. In dark red, the top expanded clone with its frequency. So that's what a polyclonal healthy repertoire looks like. Similarly, in atopic dermatitis. In atopic dermatitis, you might get a bit of oligoclonal expansion due to potentially environmental allergens, but overall, the top clone frequency is below 10%, whereas in lymphomas, usually the top clone frequency is far above 10%. So this is, at least experimentally, of course, not a routine diagnostic test, but in our hands, in the lab, in an experimental setup, this margin of 10% top clone frequency usually gives us a very good idea whether something is actually a lymphoma or a chronic inflammatory skin condition. We tested the single cell data sets first in patients that had 2 lymphomas at the same time to better understand whether differentiation is possible there or whether there's some overlap. So this is a 33-year-old female patient. She had this sharply demarcated red to brown plaques on her back, but at the same time she had these purple tumors on her breast. And to make a long story short, she suffered from both a follicular center lymphoma and a mycosis fungoides, which was not entirely clearly picked up by conventional histology. Of course, you have here in these plaques primarily CD4 and less CD8 infiltrated with loss of CD7, but the TCR rearrangement was negative, and those other lesions had a lot of B cells, but also a lot of T cells, as B-cell lymphomas can have. But when you do single-cell RNA sequencing, you can amplify T-cell receptors and B-cell receptors, and you can plot these. And here in brown, you see the top clone, the malignant clone that you find, a T-cell malignant clone that we found in those patches, whereas we found the B-cell clone in those tumors. So this was a way to differentiate those 2 conditions, and finally gave us the diagnosis that this patient suffered from 2 lymphomas at the same time. We then looked at T-cell receptor frequencies also in Sézary patients, in erythrodermic MF patients, and frequencies of the top clone were very different both in blood and skin when we compared Sézary and erythrodermic MF patients with psoriasis or atopic dermatitis, and also those difficult to diagnose or difficult to grasp cases of chronic idiopathic erythroderma where you can't really make a diagnosis, and we believe that this is sort of a separate entity. When we talk about early stage MF, I think we have to talk about parapsoriasis, which is a term that has been coined by another giant of Parisian dermatology, Louis Brock, and I can absolutely recommend you to go. This is his bust that is found in the Musée des Moulages at the Saint Louis Hospital. It's a great museum where you can see all these moulages. It's very, very impressive. And he coined the term parapsoriasis. And you know, parapsoriasis comes as small plaque parapsoriasis or digitid dermatitis or large plaque parapsoriasis. Many think it is sort of a term that is outdated and no longer appropriate to be used, but I think there's a niche for this kind of term. And we wanted to better understand what actually is going on in these patients, because many would agree that large plaque parapsoriasis is essentially the same as early stage mycosis fungoides, whereas small plaque parapsoriasis is more controversial, usually doesn't really progress to overt MF, but there was still a lot of controversy. So we took biopsies from patients with small plaques and large plaques and compared them to bona fide diagnosed atopic dermatitis individuals. You know, this study from Anna-Marie Ranke, who looked at the progress from small plaque parapsoriasis or large plaque parapsoriasis to overt MF, and these frequencies were high in large plaque parapsoriasis, but were not zero in small plaque parapsoriasis. So we performed single-cell RNA sequencing with patients from those two disease entities and compared them to healthy controls and atopic dermatitis. And here on the top, you already saw this plot of T cells where we can quantify and visualize the top clone. Here on the bottom, one column is one individual sample or one individual patient, and this enumerates the entirety of T cell receptor positive cells. And in dark red, I show here the frequency of the single top expanded clone. And here in healthy controls, you see that the single top expanded clone is just about below 10%, so this is a polyclonal picture. The same in atopic dermatitis. Large plaque parapsoriasis largely had topics or a clone that dominated the infiltrate, not in all patients, but in the majority of patients, whereas we found such a dominant clone only in 1 out of 7 samples in small plaque parapsoriasis. And I think this gives us good evidence, maybe not evidence, but a good hint that small plaque parapsoriasis might not be an actual lymphoma, because I have hard times wrapping my head around the concept that you have a lymphoma, but you don't have an expanded clone. And we are following those patients, of course, and we will see whether this is going to correlate with clinical outcome. But here with large plaque parapsoriasis, you have this strongly dominant clone, and I think we can definitely confirm that we can call it early stage MF. We wanted to then, of course, see whether those cases that do not have an expanded clone but are part of this small plaque parapsoriasis fingerprint dermatitis group, whether they had something special, because they are usually, clinically they look different from atopic dermatitis. What about the molecular level? And we looked at many, many cell types. They were all very similar, but we found a tiny little cell population that was only present in small plaque parapsoriasis, and this was a so-called innate lymphoid cell population that produced so-called neuropeptide Y. We do not know why these cells do this, but we found this cell population to be uniquely found in those of polyclonal small plaque parapsoriasis lesions, and we were also able to confirm the presence of these cells in immunohistochemistry. They are usually characterized by being CD3 negative, and in this case they were NPY positive. Again, what are innate lymphoid cells? They are sort of the innate, the non-T cell version of the immune system that can mimic the T cell arm of the adaptive immune system. There are ILC1s, 2s, 3s, similar to Th1, Th2, and Th17 in the adaptive immune system. And they were found in mice. They are present at higher frequencies in mice, and their function in humans is not really elucidated. But we believe that small plaque parapsoriasis might be a disease that is associated with this ILC population. And we think it's more of an ILC1 phenotype, which also is quite different from atopic dermatitis, because there you would assume it's more of an ILC2, IL4, 5, and 13 triggered disease, but in parapsoriasis we found more of an ILC1 phenotype. This is what we found in mycosis fungoides. We also wanted to look at the atopic dermatitis side. Are there cells in atopic dermatitis that are present or uniquely present only in AD? It's often very difficult to study human skin when you have this high amounts of inflammatory infiltrates. Everything's upregulated, Th1, Th2, Th17, Th22. So looking through this complex hyperactivated immune microenvironment in untreated AD it's often difficult to know what is really inflammatory, what is counter-regulatory, and so on. So we, in a study, wanted to better understand what's actually going on in patients that are treated, for example, in this case with dupilumab, what's remaining in the skin and what might be the component of this so-called skin immune memory. Because any atopic dermatitis patient that you treat, atopic dermatitis ideally goes away, but once you stop the treatment, the disease will come back. So there must be some intrinsic disease memory that will allow the disease to come back. And what we found was that even in patients that were successfully treated for 1 year with dupilumab, there was still a lot of inflammation going on, Th2 inflammation particularly. And when we looked at which cell sort of hibernates, which cell survives treatment in atopic dermatitis, it was a so-called Th2A cell, which is a special Th2 cell that has alamine receptors on its surface. Those are memory cells, and those are cells that can sort of sit in your skin long term and then can be easily woken up by alamines, which are usually inflammatory mediators produced by the epidermis, are induced when you scratch your skin, for example. So the concept that these cells are sitting there mediating some sort of disease memory in atopic dermatitis is, I think, quite conceivable. But the most important thing is that this so-called Th2A cell was only present in atopic dermatitis samples, was not present in parapsoriasis, early stage mycosis fungoides, and other conditions that we investigated. So these cells with this marker profile are really unique to atopic dermatitis, and it will be interesting to see whether those markers can be used as a diagnostic classifier to rule out CTCL. Those cells are also very interesting because they were shown previously that in peanut allergic patients, when they undergo peanut-specific immunotherapy, those cells go down. So this is not a direct proof, but it's some circumstantial evidence that these cells might indeed be pathogenically relevant in atopic individuals. And very importantly, those cells were absent in individuals that outgrew atopic dermatitis, or children that had atopic dermatitis but then lost the disease during teenage years, and those young adults did not have those cells anymore. And the two possibilities are, of course, the reason why those children outgrew their condition might be because they didn't develop these Th2A cells in the first place, or they somehow got rid of it, which then led to the remission of the disease. So in order to sum up, so I clearly overpromised with my title, so there's still no biomarker available that can clearly differentiate those conditions. And as you have seen also from the other speakers, the diagnosis of particularly early stage MF can be difficult. I think the absolute number one key component to diagnose this patient is still a great clinician and a great pathologist. And again, we will see whether a single biomarker will ever show up in CTCL. With all its heterogeneity, I'm not so sure. In my opinion, the single best biomarker is clonality, and we will see whether high-resolution molecular tests will help us in the future, but we are not there yet. With this slide, I want to thank my group, my mentors, and my funders, and hope to see you all at our 6th Inflammatory Skin Disease Summit in New York in November. Thank you so much.
Thank you so much, Patrick. So why don't you come on over? If I can ask our distinguished speakers, Amy and Pietro, if you can join us on the stage. And we have a few minutes to take questions from the floor. So if anybody wants, I think there's microphones across the rooms. Yes, please.
Hi. Thank you all for your speeches. It was wonderful, all the lectures. I wanted to ask a question for Professor Hodak, if possible. Hi.
Hi.
So I'm a resident from Istanbul, and I see around 70 patients per day. That's why we have a very large amount of patients in our clinic, and we have around 460 patients with early MF that we have diagnosed and have been following. So my question is, we can have some questions when we're looking at children with atopic dermatitis or atopic dermatitis-like lesions, but to make the decision to take a biopsy, especially when they are very small, when they're like 2 years old or 4 years old, it's very hard to do that. So we can have those questions, but when do you decide to take the actual biopsy? And there comes the second question. You don't always get the actual diagnosis if it's MF. On your first biopsy, you need to take like 5 biopsies sometimes, or you need like 4 years of follow-up sometimes. So how do you make that decision when you see only one plaque, like keratosis pilaris-like lesion, only one part of a 2-year-old kid's arm? So it's really hard to make that decision because you don't know if you're going to have the actual answer from the dermatopathologist. That's my question.
Thank you for raising such important aspects in our daily practice. In fact, I showed cases that were not covered by 1 lesion, 2 lesions. They were long-lasting, multifocal lesions. So I totally agree with you that it's very difficult to obtain biopsy from a 2 to 3-year-old child. And if I think the index of suspicion is not very high, and there are only very, very limited lesions, I'm not sure that it malpractice to postpone the obtaining biopsy for older age, and meanwhile to recommend applying topical steroids, because anyhow, the treatment, the first-line treatment in palsy lesional MF, flat lesion, would be topical corticosteroids. So we don't make any mistake if we, 1, don't obtain biopsy, secondly, if we give or recommend topical steroids. And of course, the child should be under surveillance. So I think it's totally legitimate. So thank you for raising these points.
Just a little more question, a follow-up question. So we follow up all of the patients, adult patients, that we even have a question of MF for every 3 months.
For what? Excuse me?
3 months.
Every adult patient
3 months?
we have, that we have a question of MF, not any pathology. We follow up them for 3 months, every 3 months, because it's easy to follow up in our case. It's free, they don't pay any money. But for children, do you recommend an amount of time we have to follow them up? Like, for example, every 6 months or every year until their age of 5 or anything like that from your clinical experience?
I think if you think about MF and you put it in your differential diagnosis, I don't find any reason why there is different approach to adults than to pediatric population. I would invite them every 3 to 4 months to see what's going on. You know, you speak with the parents, you raise some suspicion. You can't, I can't leave them for 12 months until the next follow-up visit. I think also the parents won't be happy with such low-frequency follow-up policy.
Thank you.
Larry?
Hi, Larry Eichenfield from UC San Diego. First of all, I thank you for a great session, phenomenal lectures. So Professor Hodak, I want to, staying with the pediatrics question, it's, in a way, it's tremendously reassuring that in your experience as one of the world leaders in cutaneous lymphoma, you've seen one case of advancement of pediatric CTCL. Because in pediatric dermatology, one of the major questions we have is how important is it to make an early diagnosis of cutaneous lymphoma in a child? Most commonly with the beautiful presentations you showed with hypopigmented MF or follicular trophic, where most of those tend to not have a history of acceleration, and that's one of the issues we faced when we come together to say what should be standard therapies, and we say how many people here have had cases that have moved on to need for systemic therapy, and there's quiet in the room. So I guess my question is, how do you handle it therapeutically, standardly, topical steroids, maybe phototherapy? Is there anything else that you've learned from your experience? And do you think that there may be more directed therapy in the future that might be important as a way to manage it other than essentially symptomatic anti-inflammatory treatment with topical steroids?
The therapeutic approach to pediatric early stage is quite similar to early stage in adults with some asterisks. One asterisk that we don't give PUVA because of the safety precautions. And in cases there are follicular lesions, we recommend, based on our experience and also the modified Delphi, that was the methodological basis of our recommendation, to give other types of UVA-based treatments, like UVB, narrowband UVB plus UVA. So this is my experience with my colleague that is sitting here, Dr. Friedland, which she is the head of the pediatric unit in Schneider Medical Institution, which I collaborate with this unit for more than 25 years. And we have, I think, a good experience with narrowband UVB and UVA for follicular tropic. So if you ask me what's the difference, in adults, I will tend to give PUVA. In children, I won't give PUVA. But otherwise, the treatment for early stage MF in adults is more or less similar. In refractory cases of early stage MF, when we do have cases with extensive early stage MF, 1B but high 1B, and many, many follicular lesions, we sometimes give not only UVA and narrowband UVB, we add also acitretin. And usually we try to avoid interferon alpha, now PEG interferon / Besremi, because of the deleterious effect on the growth of the child during adolescence. So we try, if we want to give him interferon-based treatment, to give the child before the surge of the growth, because otherwise it will have a deleterious effect of his final height.
Thank you.
Any more questions from the floor? Yes, please.
Emilia, do you prefer acitretin instead of isotretinoin in the MF?
I don't have, well, we usually give acitretin, but I know there are physicians that give isotretinoin, and I'm not sure there is a big difference. I'm not sure. Okay. But most of the literature is on acitretin and less on isotretinoin. But if you look at NCCN guideline, it's equally cited.
Yes, I know. Thank you.
Okay, so thank you for this great first part of the session. We're now going to take a break. We'll reconvene at 4, where we're going to have some great talks looking at the advanced therapeutics in atopic dermatitis and what's known today.